Good morning, everyone. As Dr. Afshar told, so today I'll be talking about the urinary stone disease in children. Before I start my presentation, I have no disclosures to make with respect to this presentation or otherwise. So, for today's talk, the learning objectives would be to have an overview of the changing epidemiology and the contributing factors for urological stone disease in children. Then I'll talk about the other objective would be the importance of metabolic workup and role of genetics in children, and an overview of the management challenges and special considerations we have to keep in mind while managing the pediatric cases. So the contents in today's presentation will be starting with the changing epidemiology and contributing factors, then the major differences between the adults and the pediatric stone disease. We'll touch a little on etiology and pathophysiology and talk in detail why metabolic workup is so important in children and the possible role of genetic testing for recurrent stone formers. Then I'll come to the challenges we face when managing a kid with stone disease and what all special considerations have to be kept in mind for that. There has been a dramatic increase in the reported incidence of symptomatic pediatric stones in the recent years, and it is commonly flashing all over the news in the newspapers and media. Some large pediatric studies, they have reported a near five-fold increase in the incidence in the last decade, while a systematic review found a 6 to 10% annual rise in stone incidence over 25 years. Just like the other parts of the world, similar trends were seen in a single center study conducted by Children's Hospital of Eastern Ontario, where stone incidence in children undergoing abdominal imaging more than doubled in a 5-year period between 2011 and 2016. Notably, asymptomatic stones were detected almost as frequently as the symptomatic stones. Given the life expectancy of the child and high likelihood of recurrent stone formation, this places a strain on the healthcare systems, requiring specialized care and recurring follow-ups, making the economic burden substantial. A study from United States, it estimated a minimal annual cost of $375 million for diagnosis and management of pediatric urolithiasis. Coming to the sex distribution, so during the first decade, the stone disease is more prevalent amongst the boys, mainly due to the higher prevalence of UTIs in this age group. However, in the second decade of life, it is the girls who are affected more than the boys. And the suggested theories for female predominance, most often they come from the adult literature and include difference in the hormonal milieu and increase in the female obesity. But it remains unclear whether these theories they apply to pediatric patients or not. But most of the pediatric series, they report female predominance in the adolescent age group. And in the race, whites are affected more than the Hispanics, blacks, and Asians. Now, the reason for the increasing stone incidence in children, it is mainly attributed to the changing dietary habits and the lifestyles, with increased consumption of processed foods, which are very high in salt, and consumption of the sweet beverages, as well as the lifestyle changes leading to reduced physical activity and higher obesity rates. Although there are conflicting results on relationship between obesity and stones in the pediatric population, but increasing number of children with metabolic syndrome, they are known to have a higher risk of insulin resistance, which increases the urinary pH and is believed to be the cause for increasing stone disease. In addition to that, certain therapeutic diets like the ketogenic diet given for the epileptic kids, that is also known to increase the stone disease incidence in children. Environmental factors such as rising temperature and changes in hydration habits, they also play a role in this increasing trend. Improved access to the healthcare has been responsible for the increased number of asymptomatic incidentally detected stones in children. And the premature infants, they may represent a new population of stone formers, and this is attributed to the modern medicine, which has made survival for many of these preterm neonates possible and is often related to their critical management in the NICUs with loop diuretics, carbonic anhydrase inhibitors, and antibiotics. Coming to the clinical presentation and the risk factors. So in the pediatric age group, they are age dependent and they keep on changing. With most of the newborns who are premature and very low birth weight, they are mostly asymptomatic and mostly incidentally diagnosed on their imaging done for other workups. And as pointed out earlier, the risk factors during this neonatal period, they include a history of hospitalization with use of nephrotoxic medications and diuretics. The infants, they mostly present with non-specific symptoms like irritability, poor feeding, crying attacks. Consequently, the diagnosis that can be easily missed in this group of patients, and they can subsequently develop complications of the stones such as obstruction and infection and even life-threatening sepsis. The risk factors identified in them are congenital anomalies, and mostly metabolic and genetic disorders are the ones that contribute in this age group. And beyond 1 year, it is the infection which mostly predominates, and after 6 years, it is the idiopathic causes. The school childrens and the adolescents, they present more or less like the adult patients only, with classic flank pain and hematuria. And hematuria is a symptom which is common across all the age groups. Talking about the differences between the adult and the child stone disease, although the prevalence of stone disease has increased in children, still it is less common when we compare it to the adults. And unlike adults, where the stone disease has a strong 2 to 3 fold male predominance, the sex distribution it is more even in children, with adolescent girls predominating in most pediatric series. In contrast to adults, where urolithiasis is most often idiopathic or diet induced, a cause is found in most of the pediatric patients with the metabolic disorders predominating. And pediatric stones, they are known to be notorious for recurrence, with 50% of them recurring in 3 years, which would typically be like 5 to 10 years in case of adults. Thus, in the background of high recurrence and identifiable cause in most of them, kids are more aggressively evaluated and they require a multidisciplinary care. Talking about the stone composition, the composition of kidney stones in children that has undergone significant and noteworthy change, with the distribution now closely resembling that seen in adults, with the current series indicating the prominence of calcium oxalate and phosphate stones over the infectious stones, and uric acid stones being the least common one. The similarity in composition between the pediatric and adult kidney stones again highlights the pervasive nature of the specific dietary and the lifestyle factors across all the age groups. So, in addition to the stones that we usually see, so I found this bizarre melamine stones which were found in China. So, in September 2008, WHO reported an outbreak of urolithiasis among young children because of ingestion of this melamine contaminated infant formula. Coming to the etiology, as far as the cause of the stone disease in children are concerned, there are 3 kinds of risk factors, and most of the patients have at least one of these risk factors. The first is the metabolic, which can be identified in 75 to 90% of the cases and results either from the solute excess or decreased concentration of inhibitors, to which I'll come in my subsequent slides. The other risk factor is the anatomic, which is seen in 10 to 25% of the cases and is mostly related to the flow and physics, where anatomic anomalies lead to stasis and then stone formation. And some classic examples are the UPJ obstruction or horseshoe kidney. And finally, the infectious factors. Up to 20% of the kids, they have UTI. And the question is whether these infections are causing the stones or these kids are predisposed to the infection because of the anatomic causes. Urinary tract infections with urea splitting organisms such as Proteus, Klebsiella, and Pseudomonas, we know that they increase the ammonium and the urinary pH, which leads to supersaturation of magnesium, ammonium, and phosphate, leading to the formation of struvite stones. And these infective stones, they typically present in the preschool boys, probably reflecting the congenital anomalies of the urinary tract that impair the drainage and thus predispose to infection. In rare cases, the stones can lead to chronic infection and culminating into xanthogranulomatous pyelonephritis and loss of the kidney function, emphasizing the importance of recognizing and treating these stones. But even in the stones which are not initially caused by infection, these bacteria may contribute to the stone formation and growth by reducing the urinary citrate and forming the crystal bacteria aggregates that bind to the epithelium and promote the deposition of the matrix proteins. In 2002, a retrospective review studying the clinical outcome of the pediatric stone disease found that 50% of the patients under the age of 10 years presented with nephrolithiasis as a result of metabolic disorder. And this results because of the imbalance between these 2 factors. Either there is too much of solute or too few inhibitors, too little solvent, or too many promoters. The commonest biochemical abnormality associated with urinary stone disease in children is hypercalciuria. It has many different etiologies, but the most common amongst the pediatric population is idiopathic hypercalciuria, and it is characterized by normocalcemia, and there is no increased dietary calcium intake which is contributing to this. Although the precise genes that contribute to the idiopathic have not been identified, but it follows an autosomal dominant pattern with incomplete penetrance. The other risk factors are the premature birth, immobility, seizure therapies, and distal renal tubular acidosis. Hyperoxaluria is another common cause, and this can be primary or secondary. The primary is mainly caused by the increased endogenous production of oxalate in liver, and there are three types which have been recognized. Type 1 is the most common one. The secondary ones include the enteric hyperoxaluria or the dietary hyperoxaluria. The dietary one results from the increased intake of the oxalates or the precursors or ascorbic acid, while as the enteric oxaluria, it mainly results from the conditions that lead to fat malabsorption like inflammatory bowel disease or cystic fibrosis. Since the calcium, it binds the free fatty acids in the intestinal lumen, so the oxalate loses the counter ion, resulting in an increase in gut absorption of oxalate and subsequent excretion in the urine. Hypocitraturia is another condition because citrate is an inhibitor of the calculus formation, and it mainly acts by binding the calcium with the other counter ions such as oxalate and phosphate via the calcium citrate complexation. It prevents the aggregation and growth of crystals by binding to the crystal surface and increases the pH of the urine, which increases solubility of calcium oxalate. Many conditions leading to proximal tubular acidosis can increase the citrate absorption and thus decrease this inhibitor in the urine, leading to increased chances of the stone formation. Cystinuria, it is the most common cause of inherited nephrolithiasis and represents nearly 6 to 8% of all the pediatric stones. It is an autosomal recessive genetic disorder which is caused by mutations of SLC3A1 and SLC7A9 gene mutations. This results in a defect in reabsorption of cysteine along with the other diabasic amino acids like lysine, ornithine, and arginine at the proximal renal tubular level. And at lower pH levels, the cysteine is relatively insoluble, causing its precipitation in the renal collecting systems. It has been seen that 50% of the patients with cystinuria, they present with their first stone by the age of 10 years, and another 25% of patients present in the teenage years. These stones can be challenging because there is risk of stone recurrence. They are radiolucent on X-rays, and they are resistant to non-invasive therapies like shockwave lithotripsy. Hyperuricosuria, it is the least common, and the pure uric acid stones are very rare in children. Whenever it is there, a prompt consideration for inherited disorders of urate metabolism and transport should be kept in mind. They can release either from increased uric acid excretion, which could be idiopathic or familial, or increased uric acid production in tumor lysis syndrome, blood dyscrasias, or high protein diet. Like I said previously, since 50% of the patient population under the age of 10 years presents with nephrolithiasis as a result of metabolic disorders, and these children are nearly 5 times as likely to present with recurrent stones when compared to their counterparts without a metabolic disorder. It is important that a metabolic evaluation is completed for all the children with suspected nephrolithiasis. And according to the CUA guidelines also, an in-depth metabolic investigation is recommended for all the children less than 18 years of age with the stone disease, and a complete metabolic workup. It includes the spot urine tests, the 24-hour urine collection, battery of serum tests, and stone analysis, which is considered to be the gold standard. And this complete metabolic assessment, it helps in identifying the cause of the stone formation and thus deciding the targeted medical therapy which can prevent the recurrences, which is very common in this age group, and then guiding the dietary and medical management accordingly and detecting the systemic diseases early. Another significant contributor to stone disease in children is genetics. There is a strong evidence that nephrolithiasis, it aggregates in families. Indeed, there is a threefold increase in incidence when there is a positive family history. And data suggests that 35 to 60% of the patients with stone diseases, they have a family history. Twin studies have also been shown that there is a 45% heritability factor for developing nephrolithiasis. Currently, there are 46 known genes that represent the monogenic cause of human nephrolithiasis, and most of these patients they carry recessive mutations. The monogenic causes they are implicated in 30% of the kids, and those with monogenic disease have disease onset before the 10 years. And these mutations they can lead to various nephrolithiasis disorders, including the DEN disease, Lowe syndrome, renal tubular acidosis with osteoporosis, Bartter syndrome, and hypocalcemia. Although the clear-cut role of these genes in the recurrence is not that well established, but two genes SLC34A1 and TRPV5 have been found to be associated with recurrence in some of the studies, and it has been found that the patients with these genetic mutations are more likely to have the recurrent disease and have more frequent recurrences. Talking about the role of genetic testing, the current clinical evidence for the role of genetic testing in the kidney stone disease is comprised of 9 cohort studies in which it has been found that the genetic diagnostic yield is maximum in children and young adults who are less than 25 years, and it is between 12 to 21%, whilst in the adults, it ranges in 1 to 11%. And in unselected patient cohorts, the yield goes down further with only 1 to 3% of the adults carrying monogenic variants. Diagnosing the genetic disorders, it helps in providing the targeted therapy, early diagnosis, which may present the chronic kidney disease in the long term, and it also helps in screening of the family and prevention, and also provides evidence for funding. Currently, the Canadian Urological Association guidelines they do not recommend genetic testing as a first-year diagnostic tool for the pediatric patients with isolated kidney stones. However, it may be recommended as a future direction in patients with recurrent nephrolithiasis. Genetic testing was previously too costly and unavailable to many patients, but this has changed with the new advancements in the next sequencing techniques, allowing patients to receive genetic evaluation at reducing costs. In many instances, the comprehensive panel is denied funding, therefore, the wholesome sequencing is completed. But more often through enrollment in research projects. In Canada, genetic testing is available with government funding, and lumisiran is a novel RNA therapy for primary hyperoxaluria type 1, which has been recently approved by Health Canada. Coming to the management, the management of urolithiasis in the pediatric population, it presents unique challenges due to the specific anatomic and physiological characteristics of the children and their higher tendency for metabolic abnormalities and stone recurrence, requiring a multidisciplinary care compared to the adults. So before coming to the management, it's important to talk about these specific challenges. The dietary advice. Children have a higher body water content relative to their body mass and higher water requirements per unit of body weight if we compare them to the adults. Anyhow, in case of pediatric urolithiasis, whatever its cause, it is of utmost importance to increase the water intake to around 1.5 to 2 liters in most of the cases, and 3 liters per meter square also per day for some genetic lithiasis on an average to dilute the urine, which may be challenging to achieve in case of children. And sometimes in infants and in children, a feeding tube or gastrostomy may have to be done. The other challenge is the unpleasant taste of certain drugs like soda bicarb and potassium citrate, which makes it difficult for the parents to administer these drugs. And the restriction on animal protein intake is usually not indicated and may adversely affect the linear growth and development of young children. Additionally, as the calcium reduction paradoxically increases the stone risk and may negatively impact the bone health and development, moderate calcium intake is recommended for most of the pediatric patients. Then there are several anatomic differences unique to the children that should also be taken into consideration when evaluating for surgery. First, the smaller body habitus and urethral diameter that may make ureteroscopy challenging in these patients. And most of these patients, they require pre-stenting, which requires general anesthesia, which has its own implication in this age group. Because of the smaller size, in case of ASWL also, there is always a risk of lung radiation, although that can be reduced by placing the sheets. And they have more mobile kidneys, as a result of which the access during the PCNL procedures may not be that easy. And there are usually complex congenital anomalies and anatomies like duplex ureters, which make this group of patients more challenging. Radiation exposure, because children have rapidly growing tissues and are expected to have longer life expectancy than adults, minimizing the level of radiation exposure is of particular importance in this age group. Undergoing evaluation or treatment for nephrolithiasis, the International Commission on Radiological Protection, it recommends an annual radiation exposure limit of 20 millisievert averaged over 5 years, with no single year having more exposure than 50 MSV. But according to many of the studies, this amount of radiation, this can be received from a single nephrolithiasis therapeutic plan, including the detection as well as the management. And both European Society of Pediatric Radiology and the AUA have recommended ultrasound as the initial imaging modality for evaluating the suspected renal calculus in order to limit the radiation exposure. In a prospective study evaluating the precision of ultrasonography, it was reported that ultrasound has 76% sensitivity with 100% specificity in the detection of urolithiasis in children. Upon further analysis, the lower sensitivity rating on the ultrasound was due to ultrasound not identifying the stones of small caliber, which were anyhow not clinically significant. And the sensitivity of the urethral stones, that detection may also be improved by combining the ultrasound with X-ray KUB, as this would allow for better stone localization. Low dose CT with dose reductions up to 50% have been demonstrated not to affect the diagnostic capability in patients with suspected urolithiasis. And meta-analysis for urolithiasis in children also yields a sensitivity and specificity of 96 and 94% respectively. Recurrence is another challenge in the pediatric age group. Some studies estimate the probability of symptomatic stone recurrence to be 50% within 3 years of the stone event if the intervention is done, and without an intervention, it increases to 75%. And those with metabolic disorders, they are known to have nearly 5 times more chances of recurrence when compared to their counterparts without the metabolic disorders. Levi et al. In 2020, he found that patients who experienced their first stone episode before the age of 20 were more likely to have multiple recurrences compared to those who presented later. Thus, it becomes very important in this age group of patients to do an in-depth metabolic workup, and as such they need metabolic disciplinary care involving a nutritionist, nephrologist and urologist, and preventative management focusing on lifestyle and dietary changes. Coming to the management now. So the AUA guidelines for the management of kidney stones recommends that pediatric patients presenting with asymptomatic and non-obstructed renal stones can be offered evaluation for underlying metabolic abnormalities, assessment of the urinary stone risk parameters, and periodic ultrasound surveillance, with emphasis to the parents or caregivers on the importance of regular follow-up. Talking about the medical expulsive therapy, urethral stones in children can spontaneously pass in about 32 to 63% of the times. So a trial of passage is worth pursuing in majority of the cases, particularly in older children with stones less than 5 millimeters in the size located in the distal ureters. The adjunctive use of MET therapy with alpha blockers and calcium channel blockers has been well documented for uncomplicated urethral calculi in adults, but studies on MET in children for stone disease, they are limited. And the desire to use MET in children, it stems from the goal of mitigating risks associated with the surgical interventions, anesthesia, as well as the radiation exposure while using the fluoroscopy. Furthermore, many of these patients, they will have more stone events throughout their life, confounding the effects of these anesthesia, surgery, and radiation further. In 2009, FDA approved tamsulosin for the treatment of bladder outlet obstruction, but the formal approval for its use for pediatric stone management has not been granted, but it is widely used by the pediatric urologist as an off-label drug. McG et al. In 2021 reported higher primary or initial ureteroscopic access rate in children who were treated with tamsulosin 1 week prior to the ureteroscopic stone surgery. So this preliminary data would suggest that MET may stand to improve the surgical outcomes and minimize anesthesia and radiation exposure, even if not effective in stone passage. To date, there have been 6 randomized control trials examining the role of these medications in children with distal urethral calculi, and a 2022 systematic review And meta-analysis of all these 6 studies indicated that the medical treatment in children with uterine stones could significantly increase the stone expulsion rate and also decrease the stone expulsion time. However, the adverse effects in the treatment group were significantly more than they were seen in the control group, but they were not very significant, mostly included headaches, dizziness, and congestion. As per the AUA recommendations, surgical management, it should be considered for symptomatic renal and urethral stones that are unlikely to pass spontaneously or have failed to pass after a trial of conservative therapy. So we have various options like ureteroscopy, shockwave lithotripsy, and percutaneous nephrolithotomy. But the common goal of surgery is to clear the stones by the most efficient yet least invasive manner and with the least risk of repeat procedures and complications, particularly in view of the recurrent stone disease in children. In all these procedures, the aim is to either break the stone into smaller fragments, tiny enough to subsequently clear with the urine, or to remove the stone and all its fragments. But notably, insignificant residual fragment is a misnomer in children, and considering that 1/3 will regrow over a period of 1 to 4 years. So there is no consensus on what size of stone fragments in pediatric patients are large enough to be clinically significant or small enough to be cleared without adverse clinical outcomes. Coming to the extracorporeal shockwave lithotripsy, which is the mainstay of treatment in most of the pediatric patients. The use of Aswell in pediatric nephrolithiasis was initially delayed for many years until 1986 due to worries of potential adverse outcomes related to children's organ development. However, now it is a treatment of choice for the patients with suitable stone size. In comparison to the adults, children may be considered better candidates for Aswell because of their shorter, more distensible ureters, their smaller body habitus, and the resultant shorter skin to stone distance and high water content, which reduces the acoustic, which results in low acoustic impedance. According to the 2022 European guidelines also, it has been recommended as a first-line treatment for most of the patients. Coming to the factors that affect the success of the shockwave lithotripsy, it has been found that the younger children's with lower BMI and if the stone size is less than 1 centimeter, they are found to have more success with the shockwave lithotripsy. But notably, regarding the stone location, most pediatric studies, they have shown no statistically significant relationship between the stone-free rates and location when comparing the lower pole stones with the other intrarenal stones. Which is unlike adults, where there is a general consensus that the lower pole stones, they tend to be more refractory to Aswell when compared with the other locations. Similarly, the skin stone distance was not found to be a significant risk factor for children, but that is also probably because most of the patients they do not undergo non-contrast CT, and which is likely why study of this parameter in children has been very limited to this date. Other than that, the stone composition like bruchite stones, the calcium oxalate monohydrate, calcium phosphate dihydrate, and the cystine stones, they are known to be resistant to the Aswell. Regarding the rate of the shockwave delivery, it has been found that higher success rate is seen in intermediate frequency group when compared to the high frequency. However, there is no difference between the low frequency and the intermediate frequency groups. A meta-analysis looking into the complication of Aswell in pediatric patients, they found minor complications in approximately 28% of the patients and major complications in only 3% patients. And these complications mainly included sepsis, urinoma, and symptomatic hematoma. Gross hematuria was the most common complication, and auxiliary procedures, they were required in 11.8% patients and mostly included the stent placement, while as the retreatment, it was required for 42.6% of the patients. Concerns regarding the Aswell's potential impact on the immature organs, they have been resolved by a long-term follow-up study conducted by ELNAS in 2013, extending to over 10 years, showing no effects on the renal growth or the incidence of hypertension and diabetes. Adequate targeting, lower energies, and limited number of impacts per session were found to be important factors for sparing the renal parenchyma, the deleterious effects of Aswell. In infants, the shockwave transmission to the chest can precipitate pulmonary hemorrhage and hemoptysis, but this can be prevented by placing a sheet of paper between the asphalt cushion and the patient's chest. Coming to the pediatric ureterorhinoscopy, it is the first-line treatment for distal ureteric stones in the adult population, but it is also popular for the proximal ureteric stones in children. And its first use in pediatric patients, it dates back to 1988, and its use has increased over the years, and this is attributed to the miniaturization of the equipments, advancements related to the optic systems, availability of the energy sources like laser, and increased training and surgical expertise in the endourological procedures. In a systematic review of 11 studies looking into safety and efficacy of ureteroscopy for pediatric renal stones, Sweckley et al., they found a complication rate of 12.6%, which mainly included fever, UTIs, hematuria, and postoperative pain, including the stent discomfort. And it was recommended that a twin surgeon approach with a pediatric urologist and an experienced endourologist seems the most sensible approach for achieving good results in pediatric patients. A multi-institutional retrospective study compared the efficacy and morbidity of ASWIL and ureteroscopy in managing the pediatric nephrolithiasis in upper urinary tracts. This study, it analyzed 259 procedures performed between 2000 and 2017, comprising 84 ASWIL and 175 URS treatments in children. And it was found that both the procedures, they were similar in efficacy in stone clearance for the upper urinary tract stones, including the cases with residual fragments smaller than 4 mm stones. However, the ASWIL was associated with lower morbidity, evidenced by fewer postoperative infections, reduced flank pain, and decreased exposure to the general anesthesia. Coming to the PCNL, the first use in pediatric patients was reported in 1985, almost a decade later after its use in adults. And this has been recommended for the calculi, which are more than 1 centimeter in size, and the kidney and ureteral stones that have failed other procedures like ASWIL and RIRS. Other reasonable indications include the challenging lower urinary tract anatomy, calyceal diverticulum, malrotated or horseshoe kidneys, known stone composition which is resistant to ASWIL like the cystine stones, or when there is a large stone burden. Generally, dilatation up to 24 French is accepted among the children, but the main concern is the impact of the tract and the instrument size on the kidney. However, in a series of 72 PCNLs using a tract up to 34 French in children up to 16 years, no scars could be seen on a postoperative DMSA study done by Duaba et al. In 2004, suggesting that there is no substantial loss of the functional kidney tissue. However, today there is a trend towards the smaller tract size with decreased bleeding risk with similar success rates. As such, mini PCNL, ultra mini PCNL, and micro PCNL, they have been introduced. But a close cooperation between the interventional radiologist establishing the initial tract and the urologist performing the lithotomy is a key to successful clearance and avoidance of complications. And this particularly becomes important in case of pediatric patients with specific anatomic anomalies like scoliosis, where the expertise of an interventional radiologist may be required to gain the access in such patients. A study by Lee et al. It compared the efficacy and safety of micro PCNL with ultra mini PCNL in treating 1 to 2 centimeter kidney stones in preschool children, and they found that there was no difference between the two groups in the stone-free rates. There were comparable outcomes related to the complications and the procedure times. However, they found that there was a significantly shorter hospital stay in the micro PCNL group, and they recommended that this is a relatively safe procedure when done in a carefully selected group of patients and with a surgeon who has a good experience. In the end, I will talk about the surgical trends and outcomes of the pediatric urinary stone disease treatment in Canada. A recent retrospective study by Berto et al. Analyzed data for 1,149 patients under 18 years of age in Ontario who underwent their first surgical procedure for urinary stone disease in 17-year period from 2002 to 2019, they found that older patients who were more than 12 years had a higher rate of surgical intervention compared to the patients who were 0 to 11 years. And that was presumably because of a more conservative non-surgical approach, which is utilized for younger children due to limitations with the instrument size or caliber, while the surgical intervention is more technically feasible in older children. But obviously, with the increasing time and with the miniaturization of the instruments, that has gone down. There was a significant increase in the proportion of the females surgically treated for the stone disease, concurrent with the increasing incidence in the adolescent females. There was a near significant decrease in the annual number of procedures done, and additionally, they found that a trend towards the increased use of URS over the shockwave lithotripsy was observed over the years, and the development of small caliber ureteroscopes and the increased training in endourological procedures was attributed to this trend. Among the 706 patients who were followed with a 5-year over a period of 5 years, it was found that 17.7% of them required a repeat procedure within 6 months and 20% between 6 months to 5 years, highlighting the recurrent nature of the stone disease in pediatric age group. The renal stone location compared to the urethral location and the initial treatment with Aswell were significant risk factors for repeat interventions within the first 6 months in these patients. So the take-home message is that pediatric stone disease is on the rise. Clinical presentation and the risk factors, they change with age. Ultrasound is the imaging of choice for children. Surgical intervention, it requires special considerations and collaboration between the interventional radiologist, adult urologist, and the pediatric urologist. Medical evaluation and follow-up is very necessary, and these children require a multidisciplinary care by the nephrologist, nutritionist, and the urologist. And genetics could be a future in the management of these patients. Thank you.